Welcome to MedAIc Reviews.
So, picture this. A patient is sitting on the edge of the exam table, leaning forward, and they're coughing up bright red blood.
Oh, yeah. That is a
What?
terrifying moment for everyone in the room.
Right. And your instinct, especially in the 21st century, is just to, immediately rush them down the hall, slide them into an MRI tube or order a high-res CT scan.
Oh, absolutely. I mean, we all want a machine to just print out a clean digital answer.
Yeah.
Like some incredibly expensive magic 8-ball.
Yeah, exactly. It's so tempting to rely on algorithms and imaging for certainty because a digital readout feels definitive.
It does. But long before a machine even boots up, I mean, that patient's body is actively broadcasting exactly where the bleeding is coming from and why it's happening. You just have to know exactly where to look, tap, feel, and, listen.
Which brings us to today. Welcome to another deep dive. Today, we're handing you the ultimate study guide, the same kind used by medical students to pass their clinical exams.
So we're doing it so you can decode the hidden signals of your own body, too.
Right. We're opening up the gold standard physical diagnosis guides. So think Bates's guide and core internal medicine notes to unpack the 4 foundational skills of examining the respiratory system. So that's inspection, palpation, percussion, and auscultation.
And we are going to pressure test those skills against a pretty terrifying clinical scenario, hemoptysis.
Which is the medical term for coughing up blood, right?
Exactly. Navigating a symptom that's severe requires a deeply systematic approach, one that starts the literal second you walk into the room.
Okay, so let's unpack this. We start with inspection, just the art of observation, sizing up the patient's overall physique, their posture, listening to the raw quality of their voice for any hoarseness.
Yeah, and you actually start at the extremities. You look at the hands.
Checking the fingernails for clubbing, right. Or for peripheral cyanosis, that sort of bluish tint in the nail beds.
Spot on. And then you check the lips and the tongue for central cyanosis. And what's really fascinating here is the distinct physiological mechanism behind those two types of cyanosis.
Right, because they mean completely different things.
They do. So central cyanosis in the lips or oral mucosa, that's a direct signal of systemic hypoxia. The blood leaving the heart simply isn't carrying enough oxygen from the lungs.
So it's like a failure at the source.
Exactly. But peripheral cyanosis out in the fingers or toes might just be peripheral stasis.
Meaning the oxygenation at the core is fine?
Yeah, the core could be perfectly fine, but the blood flow out to the extremities is sluggish, maybe due to a failing heart pump or, honestly, even just exposure to a cold room that's constricting the blood vessels.
Wow. Okay, so you're constantly hunting for signs of respiratory distress. A normal, relaxed adult takes about, 14 to 23 quiet breaths a minute?
Around there, yeah. It's usually a very quiet automatic process.
But when a patient is struggling to pull in air, the body violently recruits backup systems. You look for flaring of the nostrils, the alanasi.
Yes. Nasal flaring is a huge red flag.
And you look for intercostal or subcostal retractions, right? This is where the skin literally gets sucked in between the ribs during inspiration.
Yeah, because the negative pressure inside the chest is just so intensely high. Normally, breathing is powered mostly by the gentle drop of the diaphragm. But when there's severe asthma or COPD or some upper airway obstruction, the diaphragm just isn't enough.
The patient has to recruit accessory muscles.
Exactly. You'll actually see the muscles in the neck, specifically the sternocleidomastoid and the scales contracting violently. They're physically hoisting the ribcage upward to rip air into the lungs.
Which perfectly explains why you sometimes see a patient sitting on the edge of the bed in that classic tripod position.
Oh, the tripod position, yes. Leaning forward with their hands braced hard on their knees.
Yeah, it's like locking the wheels of a heavy crane before you try to lift a massive load, right? By locking their arms and bracing their hands, they stabilize their shoulder girdle.
That's a great way to put it. It gives those neck muscles a solid mechanical foundation to pull the rib cage upward and, overcome the airway resistance. The body instinctually optimizes its own mechanical leverage when it's suffocating.
It's incredible how the body just knows to do that. And you also have to observe the actual rhythm of the breathing, like Cheyne-Stokes breathing.
Oh, yeah. That is a profoundly important pattern to watch for. It's this crescendo-decrescendo pattern.
Where they take deep, fast breaths, which gradually diminish in effort, right?
Exactly. And it ends in a period of complete apnea, so no breathing at all, before the whole chaotic cycle starts all over again. It often points to severe bilateral damage in the brain or profound heart failure.
So we're looking at the breathing, but the actual architectural shape of the chest is just as critical. I mean, a healthy chest is symmetrical and elliptical, But diseases warp that container.
And the shape of the container dictates how well the lungs can actually expand.
Right. Like in severe emphysema, the lungs lose their elastic recoil. They can't deflate properly, so they hyperinflate. Over the years, this chronically trapped air literally pushes the ribs outward.
Creating what we call a barrel chest. It's almost as deep front to back as it is wide.
And you might also encounter the pigeon chest, where the sternum protrudes outward, which you see in like childhood asthma or rickets.
Right, and then you have spinal deformities that twist the entire ribcage scaffolding, like kyphosis, which is a severe outward curvature of the thoracic spine, creating a hunchback, or scoliosis, which is a lateral sideways curvature.
But there's a highly specific one called gibbous, right?
Yes, the gibbous deformity. It's not a gradual curve at all.
It's a sharp, angular, wedge-shaped deformity of the spine. And when you see a gibbous deformity, you are often looking at the aftermath of a collapsed vertebra, frequently caused by a fracture or by Pott's disease.
Which is tuberculosis of the spine, yeah.
So if our coughing, bleeding hemoptysis patient has a completely asymmetrical chest due to something like a gibbous deformity, we know right away their lungs can't possibly be ventilating symmetrically.
Exactly. If the external scaffolding is compromised, the internal organs are compromised. That's why visually assessing the movement of the chest wall is your final observational step here.
Right, checking for a unilateral lag.
Yeah, if one side of the chest lags behind the other during a deep breath, it's a massive clue that something localized on that specific side is restricting movement.
Okay, so your eyes tell you the chest is struggling to expand, but sight cannot tell you if that struggle is due to, like, a collapsed lung, a pocket of fluid, or a solid mass of tumor tissue.
No, it can't.
So to figure out what's actually happening under the skin, you have to move from the visual to the physical. You have to physically test the chest's mechanics and density. So we're moving to step 2, palpation and percussion.
Right, and palpation starts right at the center. You gently place your fingers in the suprasternal notch, that's the little dip at the base of the neck, to check the location of the trachea.
The windpipe should be perfectly midline, maybe just a fraction to the right.
Exactly. But if that trachea is deviated laterally, you have a major emergency on your hands. A deviated trachea means the pressure dynamics inside the chest cavity are completely disastrous.
Meaning something is either pulling it, like a collapsed, shrunken lung, or something massive is pushing it, like a tension pneumothorax.
Yeah, where trapped air is literally crushing the heart and lungs to one side. It's terrifying.
Once you confirm the airway is midline, though, you manually assess that chest expansion you were just observing. So you stand behind the patient, place your hands on their lower back around the 10th ribs, and grasp the rib cage loosely.
And you point your thumbs toward the spine so they almost meet in the middle, and ask the patient to take a massive breath. In a healthy chest, your thumbs should glide apart symmetrically, maybe 5 to 8 centimeters.
But if one thumb stays closer to the midline and lags behind, you've confirmed a localized restriction.
Right. The patient might be splinting, purposely restricting their breath because of, say, a fractured rib, or there could be underlying pleural disease or intense scarring from something like asbestosis, preventing that lung from inflating.
Okay, and next you test acoustic impedance through tactile fremitus. This is where you place the bony, ulnar part of your palms on the patient's back and ask them to loudly repeat a phrase like 99.
Yeah, 99 is the classic phrase. You're feeling for the mechanical vibrations of their vocal cords transmitting down through the tracheobronchial tree and out to the chest wall.
Okay, let me push back on this for a second, though.
Sure, go for it.
Is tactile fremitus really that precise of a diagnostic tool? I mean, in an era where a doctor can literally pull a portable ultrasound probe out of their pocket, is placing your hands on a back and feeling for 99 just like an outdated art form?
That's a really fair point, and honestly, it's a debate happening in medicine right now. Tactile fremitus is an imprecise technique. You are obviously not going to diagnose a microscopic cellular pathology with your palms.
Right.
But its immense value lies in being a nearly instantaneous, non-invasive screening tool. It directs your attention. It maps out the gross asymmetries of the lung fields in, like, 10 seconds. It tells you exactly where to focus your deeper investigation.
Because it's pure physics. It's about how sound waves travel through different mediums.
Exactly. The vibrations you feel are decreased or completely absent if the sound hits a barrier.
So if a patient has a really thick chest wall, or if there's a pleural effusion, which is a thick layer of fluid trapped between the lung and the ribs, that fluid acts as an acoustic dampener.
Yes. The low-frequency rumble of the voice hits the fluid, scatters, and the vibrations you feel are incredibly faint.
But conversely, sound travels much faster and more efficiently through a dense, uniform solid than it does through spongy, air-filled tissue.
Right, which brings us to consolidation. If a lobe of the lung is entirely filled with fluid, pus, and cellular debris, which is the hallmark of lobar pneumonia, that solid mass conducts the sound of the patient's voice straight from the airway to your hand.
The fremitus is intensely increased. The chest wall literally buzzes against your palm.
It really does.
Yeah.
Which naturally brings us to percussion. If palpation is feeling the vibrations the patient makes, percussion is you creating the acoustic waves yourself.
It is exactly the same principle as tapping the drywall in your living room to find a wooden stud, isn't it?
That is the perfect analogy. You tap along the empty, hollow drywall, and it echoes with a certain resonance. But the moment you tap over the solid wooden beam, the pitch immediately changes to a flat, dead thud.
You're setting the chest wall and the underlying organs into motion to establish whether those tissues are air-filled, fluid-filled, or solid. And the physical mechanics of the tap must be flawless to get an accurate sound.
Oh, technique is everything here. You don't just, slap the chest.
Right. You take the middle finger of your left hand, the pleximeter finger, and you hyperextend it, pressing the very last joint firmly against the patient's chest. And you have to lift your other fingers off the skin so they don't dampen the vibrations.
Exactly. Then you use the tip of your right middle finger, the plexor finger, and with a sharp, relaxed flick of the wrist, you strike the pleximeter finger.
And the withdrawal of the striking finger must be instantaneous, right?
It has to be. If you leave it resting there, even a fraction of a second too long, you mute the acoustic wave you just generated. It has to be a brisk, bouncy staccato strike.
When you execute that perfectly over healthy, air-filled lungs, the note that bounces back is called resonant, a low-pitched, clear, hollow sound.
But if you tap and hear a dull sound, you've found your wooden stud. The air has been replaced by fluid or solid mass.
So in our hemoptysis patient, if we find a sharply localized area of dullness, we might be percussing directly over a dense lung tumor, an abscess, or a hemothorax where heavy blood has pooled.
Exactly. And on the opposite acoustic extreme, you have hyperresonance. This happens when there's far too much air trapped under the chest wall, acting like an overinflated drum. You hear this bilaterally in severe asthma or emphysema.
But if you hear it unilaterally on just one side, you might be tapping over a massive pneumothorax, a collapsed lung where free air has flooded the chest cavity.
Or a large bulla, which is a fragile balloon-like pocket of trapped air in destroyed lung tissue. And you do this as a systematic grid. You strike, listen, cross to the other side of the spine, strike, listen, and compare.
You're literally building a three-dimensional topographic map of the lung's density purely through acoustic feedback. That is so cool.
It really is.
Okay, so we've mapped the density of the container. Now we have to listen to what's flowing through the plumbing. We transition to auscultation, putting the stethoscope on the chest.
Right, listening to the dynamic internal symphony of air flowing through the tracheobronchial tree. And there's a brilliant piece of advice here. Before you even put the earpieces in, ask the patient to cough once or twice.
Oh, to clear out mild, temporary airway mucus.
Yeah, because that can create confusing, irrelevant noises.
Yeah.
Once the airways are clear, you listen for the baseline. The healthy standard is the vesicular breath sound. It's a soft, low-pitched sigh, like wind rustling through dense trees.
Because it originates as harsh turbulence in the large airways, but by the time it travels through the millions of spongy alveoli to reach your stethoscope, it's been filtered and softened. You hear it distinctly throughout inspiration, and it fades away quietly about 1/3 of the way through expiration.
Exactly. But the detective work really begins when you hear adventitious sounds, the abnormal added noises, like crackles.
Crackles are those short, explosive popping sounds, right? And they aren't actually caused by fluid bubbling, are they?
No, they're caused by physical mechanics. During expiration, small diseased airways collapse and stick together. When the patient breathes in, the increasing gas pressure forces those sticky, closed airways to suddenly snap open.
So that popping open is the crackle.
Exactly. Fine crackles are softer and higher pitched. Coarse crackles are louder and lower pitched. You'll hear them in early congestive heart failure, pneumonia, or bronchitis.
Then you have wheezes, which are entirely different. These are continuous musical whistling sounds.
Yeah, they happen when air is forced at high velocity through an airway that has been severely narrowed by inflammation or bronchospasm. This is the hallmark acoustic signature of asthma and COPD.
And we cannot forget the pleural friction rub. The pleura are those two slippery, serous membranes separating the lungs from the chest wall. In a healthy chest, they glide silently.
But if they become inflamed and rough, maybe from a viral infection or a pulmonary embolism, they grind against each other. It produces this harsh, grating, biphasic sound, literally like boots crunching on dry, fresh snow.
We should probably also mention the rite of passage every clinician goes through, though. Bedclothes, paper hospital gowns, and especially a patient's thick chest hair rubbing against the stethoscope can perfectly mimic the acoustic profile of coarse crackles.
Oh, absolutely. The solution is mechanical. Press the stethoscope down harder, or literally moisten the patient's chest hair with a wet cloth to eliminate the friction artifact.
Huh. Good to know. Okay, but there's an acoustic trick the body plays here that completely messes with your ears. Transmitted voice sounds.
Oh, this is fascinating.
Just like we felt for vibrations with tactile fremitus, we now listen to the spoken voice through the stethoscope to hunt for consolidation. If you ask a healthy patient to say 99, the spongy, air-filled lungs scatter the sound, so it sounds incredibly muffled.
Right. But if a lobe is consolidated with fluid or pus, it acts as an acoustic amplifier. The sound hits your ears loud and crystal clear. That is called bronchophony.
And you can test the exact same physics with whispered pectoriloquy. You ask the patient to lightly whisper 1, 2, 3. Over a healthy lung, a whisper is completely filtered out.
But place the stethoscope over a dense block of pneumonia, and that whisper transmits directly into your ears as if they are whispering right next to you.
It's so eerie. But the strangest phenomenon is egophony. Here's where it gets really interesting. You ask the patient to say a long, continuous E sound.
Right, and over a normal lung, you hear a muffled E. But if you place the stethoscope over a consolidated fluid-filled lung, that sound morphs.
It hits your ears as a nasal bleeding I sound. The patient is saying E, but you hear ah. Wait, it actually changes the vowel.
Yeah, it's wild. The fluid in the diseased lung acts as a frequency filter. It blocks and dampens the low-frequency rumbles of the E sound, but it allows the higher-frequency harmonics, which biologically form the I sound, to travel efficiently straight to your stethoscope.
Oh, wow. That's crazy.
It is a stunning example of physics manifesting as pathology.
And all of these sounds require clinical context. If you hear crackles, you have to note if they change when the patient coughs.
Very true. If a cough clears the crackles completely, it tells you the airways were just plugged with inspissated secretions, which is mucus that has become so severely dehydrated and thick, it acts like a temporary cork.
But if the patient coughs violently and those crackles persist, breath after breath, it points to permanent structural damage in the lung tissue itself, like irreversible pulmonary fibrosis or persistent fluid from heart failure.
Which brings us to the ultimate test of these skills. What does all of this mean when the pressure is truly on? Let's apply this entire sequence to our high-stakes scenario, hemoptysis.
Coughing up blood, it is terrifying for the patient. The very first clinical step is ruling out imposters, though. You have to confirm it isn't epistaxis. So a severe nosebleed simply draining down the back of the throat.
Or hematemesis, which is vomiting blood from a gastrointestinal bleed. GI blood is usually dark, acidic, and mixed with food particles. True hemoptysis from the lungs is typically bright red, alkaline, and mixed with frothy sputum.
Once you are certain the blood is originating from the respiratory tree, your diagnostic logic must immediately branch into two distinct categories. Localized causes versus diffuse causes.
Right.
So what does this all mean in practice? Let's build the narrative.
Okay, let's do it.
Imagine patient A. They've had a chronic cough, night sweats, and unexplained weight loss. During your exam, you notice a unilateral lag in chest expansion on the right side. You percuss, and you find a sharply localized area of dullness over the right upper lobe.
Okay.
You auscultate, and you hear crystal clear whispered pectoriloquy precisely over that same dull spot.
Your physical exam has isolated the bleeding to a specific geographic zip code in the chest. This is a localized issue. You are hunting for a single destructive lesion tearing into a blood vessel.
Right, and the clinical guides point us straight to pulmonary tuberculosis, a necrotic lung abscess, or a neoplastic condition.
Like a bronchogenic carcinoma, a lung tumor eroding into the airway.
Now, contrast that entirely with patient B. Patient B presents coughing up blood, but during inspection, you immediately see severe respiratory distress nostrils flaring, tripod position.
Okay, so a very different presentation.
Very different. They aren't coughing up streaks of blood. They're coughing up copious amounts of pink, frothy sputum. You percuss, and you don't find a single dull spot. You find dullness at the bases of both lungs. You auscultate, and you hear dense, popping crackles bilaterally.
This changes the entire diagnostic landscape. This is a diffuse, systemic crisis. The bleeding isn't coming from a single tumor. The entire pulmonary vascular bed is leaking.
Wait, if the patient is bleeding diffusely into both lungs simultaneously, this can't be a localized respiratory disease. The plumbing must be failing system-wide. Is this where we start looking at the heart?
Exactly. The human body does not respect the artificial boundaries of medical specialties. Diffuse hemoptysis is frequently a cardiovascular emergency.
Like conditions that cause elevated pulmonary venous pressure.
Yeah, like a failing left ventricle or severe mitral valve stenosis. It means the heart cannot effectively pump blood out to the body. That blood physically backs up into the lungs. The hydrostatic pressure inside the fragile pulmonary capillaries gets so intensely high that fluid and red blood cells are forced outward, bursting into the alveoli.
That is why the sputum is pink and frothy. It is literally serum and blood being whipped with air by the struggling lungs.
It could also be a systemic autoimmune nightmare like Goodpasture's syndrome, where circulating antibodies actively attack the basement membranes of both the lungs and the kidneys simultaneously. You can't just guess.
You have to categorize the clues. If a patient is coughing up blood but also has severe swelling in their legs and a newly discovered heart murmur, your exam must pivot to the cardiovascular system instantly.
And we must emphasize triage. Before you ever tap a chest to find a dull note, you must assess the sheer volume of blood. Massive hemoptysis is clinically defined as expectorating more than 500 milliliters of blood in a 24-hour period.
That is a catastrophic, life-threatening emergency.
Yes, the patient isn't going to bleed to death, they're going to drown in their own blood. That requires immediate airway stabilization and potentially surgical intervention.
It is all about methodically working the problem. So let's distill the ultimate study guide we've unpacked today. Whether you are dealing with a standard chronic cough or a terrifying presentation of hemoptysis, the sequence is your absolute anchor.
Inspection, palpation, percussion, auscultation.
Right. You inspect to assess the structural integrity and the physical work of breathing. You palpate to manually feel for mechanical asymmetries and acoustic impedance. You percuss to build a topographic map of the internal tissue density. And you auscultate to listen to the turbulent dynamics of airflow and fluid.
It is a rigorous checklist designed to ensure that no clue, no matter how quiet, escapes your notice. It's about profoundly respecting the physics and physiology of the human machine.
And for you, the listener, whether you are preparing for medical boards or just driving to work, understanding the sequence gives you an incredible appreciation for what is happening under your own ribs right now.
Absolutely.
Your body is this staggering acoustic and mechanical marvel. It is constantly vibrating, filtering frequencies, and echoing to signal its own state of health.
Reading those signals is an analytical art form that relies on physics, anatomy, and centuries of refined observation.
Which leaves us with a final thought to ponder. We started by talking about our modern reliance on MRI machines and CT scans. As artificial intelligence diagnostics become more flawless and as high-definition portable ultrasound devices become as common as a stethoscope in every doctor's pocket, will these intimate, sensory-based physical examination skills, feeling for a subtle vibration on a spine, listening for the frequency shift of a vowel, eventually become an entirely lost art?
It's a real question we're facing in medicine right now.
Or will the human touch, the simple grounding act of laying hands on a patient to understand their physical reality, always remain the irreplaceable foundation of healing? Something to think about next time you take a deep breath.